This episode of GT the Podcast is supported by Alcon. This special episode of GT the Podcast is brought to you by Santen Pharmaceuticals Company. MicroShunt is CE marked in Europe and approved in Canada by Health Canada, marketed under the trademarked brand name PreserFlow. It is not yet approved in the United States and is pending PMA approval from the US FDA.
Welcome, my name is Michelle Lim and I'm a glaucoma specialist at the University of California, Davis, which is in Sacramento, California. We're going to be talking about the MicroShunt, which is a controlled micro-incisional ab-externo glaucoma filtration surgery device designed to drain aqueous humor from the anterior chamber to a bleb formed in subtenon space. The device is made from a highly biocompatible and bioinert material called SIBS. I'm here with two of my colleagues, Dr. James Brandt, who is also at the University of California at Davis and a glaucoma specialist, as well as Dr. Davinder Grover, who is an attending surgeon and clinician at Glaucoma Associates of Texas. Welcome to the both of you, and thanks for joining me in this discussion. So I was wondering, Dr. Grover, if you could tell us a little bit more about the surgical procedure used to implant the MicroShunt.
Of course, I'll be happy to, Dr. Lim. Thank you for having me here. As you mentioned, it is an ab-externo procedure. And in the trial, we really tried to standardize the approach. And so it required a limited fornix-based conjunctival incision. Mitomycin C was applied with sponges, 0.2 milligrams per milliliter for 2 minutes. And then after that was done, then there was a pre-established blade. You could also have used a 25 gauge needle, 3 millimeters posterior to the limbus to make a small pocket. And when you look at the features of this MicroShunt, it has these wings, and that really fit in a pocket that you created that prevents anterior migration. And then you close the conjunctiva, and the study really took a lot of effort to make sure that this approach was as standardized as possible.
Dr. Brandt, I was wondering if you could talk a little bit about some of the early results of the clinical trial that was performed in the United States.
Be delighted to. The patients were randomized 3-to-1, and that ended up in a sample of 395 eyes with the MicroShunt surgery and 132 eyes who underwent standardized trabeculectomy. About 2/3 of the patients were phakic and the remainder were pseudophakic in this study. And these really did reflect the typical open-angle glaucoma patient that we all deal with in our clinics. Overall, 54% of the patients and 72% of the trabeculectomy patients met the primary efficacy endpoint of a 20% or greater reduction at year 1 without needing to increase the number of glaucoma medications compared to baseline. The mean pressures over time were very comparable, and towards the end of the study at the 1-year data point, the average diurnal intraocular pressure in the MicroShunt group was 14.2 and 11.2 in the trabeculectomy group. The mean number of glaucoma medications were reduced to 0.6 average glaucoma medications in the MicroShunt group and 0.3 medications in the trabeculectomy group. What is most interesting is the difference between the two groups in terms of adverse events reported in the study. Recognize that the surgeons were all very experienced with trabeculectomy and had very good outcomes with their trabeculectomy surgeries, but even in the best of hands, things like flat chambers, hypotony, and so on were found in the trabeculectomy groups. So bleb leaks, for example, were 9% or 9.1% in the MicroShunt group compared to 14.5% in the trabeculectomy group. Similar differences were seen in terms of cataract progression, loss of best corrected visual acuity, and most important were things like shallow anterior chamber, choroidal effusions, and so on, that are the bane of the existence of glaucoma surgeons, that we hate to see shallow chambers and hypotony shortly after these surgeries.
So, Dr. Grover, what are your thoughts on the outcomes of this clinical trial so far?
The thing I found most fascinating about this trial was it took on head-to-head trabeculectomy. And that's a bold and tall task. And trabeculectomy is without question the gold standard. And so I really, what was impressive about the overall theme of this trial was that it had the confidence to take on the king, and challenge our what we most people consider the gold standard. But we all know that trabeculectomy has its faults. What's interesting is that there's a floor, right? So when you have a trabeculectomy, you can get a pressure of 6, right? You can get a pressure of 4. You can get low pressures. Some are desirable, some are not desirable. But when you have a standardized outflow procedure like the MicroShunt, it really creates a different floor. And you're not going to get a lot of 6s. And so I think, some people would look at this data and say, wow, trabeculectomy did so great because their pressures are so much lower. But it's almost like you can't get that low with the MicroShunt. I mean, that's the purpose of it. There's an inherent nature of the MicroShunt to protect against hypotony. And so when I look at this data, I'm not looking at, oh man, trabeculectomy beat this MicroShunt by 3 points because it's not 11, it's 14 millimeters mercury. I'm thinking, look at this data. If I had a patient that I think would be a good candidate for this with advanced glaucoma, and I think about ages and the idea that if I can get my patients with a pressure under 15, I can stop progression. And I have a standardized outflow procedure that's efficient, that is at lower risk of hypotony, that can get me under 15. And if I can avoid doing a trabeculectomy, I think a lot of times when you're looking at this data and you see I think a lot of people were thinking that the numbers would be more similar. I just don't think it's a fair comparison, because with the MicroShunt group, you don't have the same floor effect. So the mean IOP is never going to get as low as the trabeculectomy group.
So I think you bring up a lot of great points, and thank you for speaking to that. One thing I've noticed about the results of the clinical trial is I don't think it truly captures the heartache that trabeculectomy can cause a patient and us as surgeons. One, because it's short-term data, and two, because we're looking at hard data points and not qualitative descriptions of outcomes. And so, I'm talking about those blebs you get that are avascular, white, that are going to leak at some point. Or I'm talking about patients who develop bleb dysesthesia and, come into the office every day and complain about that foreign body sensation. Studies or clinical trials like this, you can't capture that in the data unless you specifically study it. So I'm glad you brought up the topic of patient selection and who this MicroShunt might be good for, because I want to move on to that in our discussion and ask the both of you, where do you see the MicroShunt fitting into your practice in terms of the types of patients you might feel this is a good procedure for?
Well, I'm happy to jump in. I mean, we can identify a variety of patients where the hypotony that is unpredictable but can definitely happen with trabeculectomy could be potentially disastrous. A good example is the young patient with high myopia, where we're terrified of causing hypotony maculopathy. And we don't have data yet, because only a handful of myopes at that level were included in this study. Similarly, an older patient who's on anticoagulants, who you're really worried of them developing choroidals after the procedure, where you want to protect them from hypotony and the complications, the bleeding complications of that. Similarly, patients who have already had a trabeculectomy in one eye and have many of the complaints that Dr. Lim already described, and they're really reluctant to have a trabeculectomy again in what to them is their more comfortable eye that they see better with, and yet they're going to progress if we don't get aggressive. These are all scenarios where I think the microshunt will play a very important role in our toolkit.
Yeah, now that I know this microshunt is in existence, when I see patients in my everyday practice, I see people who are kind of on the youngish side, and for a glaucoma specialist, 50s, 60s even is young to us. These are potentially people that are still working, potentially in the prime of their life. And I think about offering them a trabeculectomy, and I just don't want to do it because I think, especially for a younger person who's still working age, who you don't want to, saddle them with a burden of a lot of postoperative care. I think something like the microshunt could be very helpful in this patient population. What do you think, Dr. Grover?
No, Michelle, I think both you and Jamie, when you guys were talking, it made me I had two flashbacks of something that I think are so pertinent right now. One is, as I mentioned, predictability of and standardization of this procedure. But Michelle, you talked about the patient's ability to go back to work. When you have the risk of hypotony and you need the patient to be on limited physical activity for 3, maybe 4 weeks sometimes, that really interferes with their lifestyle. And when you have a predictable outflow pathway that has an inherent nature to protect against hypotony, I feel more comfortable with the patient going back to work relatively soon. And they actually usually have a slightly faster visual recovery based on the studies in the, outside the US. But the other thing, Jamie, when you were talking, I was just imagining myself in the operating room, and that moment that we all think about when we're doing a trabeculectomy. We've performed our scleral punch, we're about to perform an iridectomy, and the eye is open. And that's the moment where you hope that your surgical assistant doesn't take extra long to hand you that suture. You're wishing you preloaded a couple of stitches, and that 5 seconds, however long it takes to close that flap, that over time I think wears on you, and you're exposing yourself to some potential risk when the eye is that hypotenuse. And when you perform the microshunt surgery and you have the maintenance of the anterior chamber, when the anterior chamber stays formed, and I think it's a much more controlled procedure. That also, I think, just provides overarching safety for the patient and efficiency in the OR, and probably fewer gray hairs for me.
I agree completely. My nightmare is when the patient starts to cough right at the wrong time when the eye is open. Dr. Lim, you have an interest for many years over bleb morphology. What do you think? You've looked at a bunch of these and thought from that standpoint. What do you think about the safety of these blebs?
Yes. So one of the things that struck me about the paper published by Juan Valle, they talked about blebs, they graded blebs in their study, and they had this nice series of photographs of what the blebs look like over time. And one of the things I noticed is the blebs seem to form a little bit more posteriorly on the eye than a typical trabeculectomy, which is right on the limbus, sometimes overhanging. And what struck me is the idea of how this could be beneficial in the long run. And so you picture an eyelid constantly blinking over a large trabeculectomy bleb and breaking it down over time and leading to those leaks that we all hate. But when the bleb is low profile and posterior, such as what I noticed in those photos, yeah, I just don't think you're going to get that kind of breakdown of the tissues. And hopefully, time will tell. Long-term results may show us that these may be less prone to leakage. So I don't know what you both have seen in your post-op patients.
I would agree. I mean, I think the blebs look, based on 30 years of doing trabs, look like they're going to be safer. And even to the point that in the high myope example I gave you, it may be very possible to use soft contact lenses. Imagine a high myope who sees extremely well using RGP lenses or even a soft lens. They may very well be able to safely use a contact lens, where I would never promise that in a trabeculectomy eye, and that's part of my preoperative counseling in high myopes that undergo trabeculectomy. Dr. Grover, do you have any thoughts on that?
No, I think you guys are both dead on. What I've always been struck by with glaucoma is, the unpredictability of blood formation. And I tell my patients, the same doctor can do the same surgery on the same patient on two different eyes and get a different outcome. And I've done surgeries on patients both eyes and have had variable blood morphology in trabeculectomy, as well as in different microshunt procedures. But I do think that the the confidence intervals or the variability is slightly more narrow when you have a standardized procedure like this. And just given the length of this microshunt and how far back it opens up from the limbus, I think it does set the stage for that bleb that Dr. Lin was talking about, the more ideal low posterior bleb that is less likely to have that lumboischemic nature.
Yeah, if you look at the measurements of the microshunt, I think it's the posterior or distal end is putting aqueous humor out roughly between 6 and 7 millimeters posterior to the limbus versus maybe just 2 to 3 millimeters in a trabeculectomy.
And flaps can be very unpredictable in terms of where the fluid comes out and scarring. So you can actually have fluid coming out after healing right at the limbus or a fraction of a millimeter back. And that's some of the inherent unpredictability that Dr. Grover was talking about, even done by the same surgeon on two different eyes.
This episode of GT the podcast is supported by Alcon.
Yeah, I'm really curious. I wanted to throw out this question. What do both of you notice about the vascularity appearance of these microshunt blebs, let's say early and later on as you get out from surgery?
That's an interesting question. And the blebs that we've seen after this microshunt, obviously, are the ones from the trial, where we were using 0.2 milligrams per milliliter of mitomycin C for 2 minutes with sponges. I'm not seeing that anterior avascular bleb. You're seeing more the more low posterior type bleb. The amount of mito that we used in the trial also, I think, protected us from having that horribly avascular, just toasted conj area, because the losses were somewhat lower. And you mentioned the one Baye study, as well as some of the studies out of Canada have shown improved outcomes, as well as similar safe blood morphologies, while increasing slightly the dose of mitomycin C. So I do think that we are seeing these more predictable blood morphologies without that anterior ischemic appearance.
That's interesting. So you mentioned dosing of mitomycin C. I'm curious about that. I know that Dr. Ahmed and Dr. Durr, two glaucoma surgeons from Canada, recently published papers on a series of microshunt surgeries that they had done. And in one of the papers, I believe they pointed out that eyes that had been done with 0.2 milligrams per milliliter of mitomycin had a higher risk of failure than eyes that had been had surgery with a higher concentration, which they listed as 0.4 to 0.5 milligrams per mil. So what are your thoughts? I mean, you're both experienced trabeculectomy surgeons that use, different mitomycin doses for that surgery. I know that we used a fixed concentration for the clinical trial, but how do you see your practice evolving with use of mitomycin in these shunts?
Having been involved in numerous clinical trials, when you design these trials, you've got to choose something to standardize on, and the choice here was to stay with the 0.2 milligram per mil concentration. And so we can't go back and say, well, what would it have been if we have a higher concentration? We will eventually, I think, find a sweet spot, and all surgical approaches end up getting tweaked and modified once they come onto market. But I think the 0.2 milligram as used in the trial is a great starting spot, but I think doctors are going to modify it, adjust it for risk factors and so on, as we already do for trabeculectomy. Nobody I know who does trabeculectomy uses the exact same dose for trabeculectomy for every patient. And I think doctors are going to learn to titrate with this procedure just the same.
Interesting. How about you, Dr. Grover?
Yeah, Michelle and Jamie, I credit the two of you for helping us in this evolution of mitomycin C use and application. My partner Ron Feldman and I think a year and a half ago, 2 years ago, wrote a review on the use of mitomycin C in filtration surgery, and it kind of chronicled the early stages of mito, the safety of it, and how the evolution over the past 10 years, 20 years has been, away from sponges, and being more comfortable with higher doses, and being more comfortable with different forms of application like injection. And Michelle, you showed a great study that showed improved blood morphology with injecting mito in trabeculectomy, and that I think gave a lot of people confidence and speaks to what Dr. Brandt was talking about, which was we all start to evolve our techniques, and you look back at the beginning stages of this trial, and glaucoma was a different beast back then. There was slightly much more careful with the use of mitomycin C, and as Jamie pointed out, that we really wanted to err on the side of caution and safety. And then now you see with the data coming out of from Juan Baez's group in the Dominican Republic, and like Ahmed and his colleagues up in Canada, they're really pushing much greater doses of mito and showing improved outcomes. So and that's what we reported in that article that we wrote. And I think we'll continue to see that we can, with these predictable microshunts that provide a more posterior shunting of aqueous fluid away from the limbus, you can safely apply mito as long as you're protecting the limbus in slightly higher doses than what were studied in these trials.
Yeah, I think it goes back to the Hippocratic Oath, at first do no harm, right?
Yeah.
And it goes to needing to standardize for science, but once it gets into the real world, you learn clinically how to titrate things like mitomycin dose. I don't make a decision on the mitomycin dose I'm going to give during a trabeculectomy until the patient is under the microscope and I feel the conj, see how mobile it is, and so on. And I think we're going to evolve to have a similar clinical feel for the MicroShunt and mitomycin dosing once we get experience with it in the wild.
Thank you to both of you. I have some questions in a different direction here. What was it like for you to adopt this new technique? And I'll say from my own experience, when I read about what this was and what the technique was, I thought, oh, okay, this is going to be easy. I'm so used to putting in glaucoma drainage devices and slipping those tubes in. And I found when actually doing the surgery, there is this learning curve, and it is tricky and a little finicky to get that flow through the tube. So what pearls can you share with me to help me put this into perspective?
So when I did the training for the procedure as one of the investigators, I would say that I had the same attitude that you did, and I was even a little bit more concerned because in our wet labs we used porcine eyes as a surrogate, and I found that it was hard to place the microshunt using a pig eye in our wet lab. And I was pleasantly surprised that when I put it in an eye in the real world, in the OR in a human, it was not as hard as that I expected. I would say that it's important, I think, for the eye not to be super high pressure. It's much harder to put it into an eye that's highly pressurized once you've made the incision. What do you think, Dr. Grover?
No, I think I agree with exactly what you've said. What I mentioned previously is what I was comforted by on the before this endeavor of starting in the trial was that I felt that each individual step of the procedure, be it the peritomy, be it the application of mito, the dissection, the tunneling, and the conjunctival closure, all those I think are known techniques in our bag of tricks that we each individually could say in isolation that feels that's in my bag and I feel comfortable doing that. So I don't think that we were tremendously out of our comfort zone at each step. You know, the unique thing was the blade that that we were provided to perform that pocket. It can also be done with the 25 gauge needle. That was like in Europe, that's how they do it. That's a more of a unique thing, but it's a slightly similar technique to advancing a glaucoma drainage tube shunt. A couple things that I thought were unique. I love the tip that Jamie mentioned. You know, your tendencies want to keep that eye firm, and if it is, it's a little more difficult to pass the MicroShunt through the scleral tunnel. The other couple of things are number one, making sure you can see that little trickle of aqueous coming out, and keeping the anterior chamber relatively formed so you can assess flow. And then two, one really technique I think is so key is when you're closing the conjunctiva. You know, you want to make sure you incorporate tenons into that closure, obviously, but also make sure that you're not incarcerating the implant with tenons. You want to make sure that implant lays flat against the sclera, and you want to lift up the conjunctiva and the tenons over the implant so that it stays in one plane. And I think, you know, you all have trained fellows, but I think more and more fellows are moving away from knowing how to really be good closers of the conj. You know, you don't have to be as meticulous when you're closing the conjunctiva doing a glaucoma drainage implant as you do with the trabeculectomy. And I still think with this MicroShunt, you really need to still be relatively meticulous on appropriately incorporating tenons in your closure and appropriately closing the conjunctiva in a way to not get bleb leaks.
So I was going to ask one of you if you could describe what the special knife looks like. And I also have a separate question on when you pass the knife, do you do kind of like this two-step movement, or do you try to smooth out the trajectory so that you enter the eye in the angle so that's not too shallow or not too deep? What's the mental concept here?
I'll take a stab at that, so to speak. The needle knife has a very narrow tip, and then it has a wider area that creates the little pocket for the wings of the implant to go in to lock in place. And there's also a marker, so you mark this 3 millimeters back from the limbus. You start at that marked spot, and my personal tendency is as I pass it, as it reaches the shoulders of the knife, I press down very slightly at the limbus to bend the track down a little bit so that the knife enters the anterior chamber relatively flat, parallel to the iris.
I do a slight two-step pass. You want to make sure this is just like anytime you're inserting a microshunt in the anterior chamber, any tube shunt in the anterior chamber, you want to make sure you protect the cornea. So I do think that that it is nice to just have a slight, you know, lift up the posterior aspect of the blade slightly anteriorly to make sure that you're, you know, parallel to the iris and well away from the cornea. A very similar technique, I think, to inserting a glaucoma drainage implant tube.
Just one other tip in terms of preventing incarceration of Tenon's capsule that I've developed is that I use an iris sweep. Once I have the implant in the right place, I put an iris sweep posteriorly over the device and lift up so that I know as I pull conjunctiva and tenons forward, it is freely mobile and not getting pulled up into the end of the tip. And I found that to be quite useful in preventing Tenon's incarceration.
Great. That's a great piece of advice. So we're going to talk about a last topic, and that is patient acceptability. So what I mean by that is, do your patients comment at all on, the comfort level that they have in the early post-op period? Do any of your patients ever share that information with you, or notice anything, especially if you've had a patient that's had one type of surgery in one eye and then the microshunt in the other eye, like say they've had a prior tube or a trabeculectomy?
Well, if you remember from the study, the patients were randomized in the operating room. And so I often had patients come in really nervous, having read on the internet about all the things that can happen with trabeculectomy. And when they got randomized to the microshunt and we saw them the next day, they would look at me and say, that was a piece of cake compared to what I was reading about on the internet.
Interesting. How about you, Dr. Grover?
Yeah, it's funny, Jamie. I just had a flashback to the trial, and when they opened the envelope, I had the same reaction. I was hoping to get the microshunt envelope, but I do think that when you look at these eyes afterwards, they just on post-op day one, they just look a little bit less calm, less irritated. Their anterior chamber is quiet. Their vision, it really hadn't changed usually from baseline. And they're excited to be able to go back to their normal activity. Some may not have anything to compare to, but as surgeons, we definitely can compare to what we see after a trabs or tubes. And I think that that the predictability provides us a lot of comfort.
Yeah, I'd have to say also, I had a patient that was randomized to receive the microshunt, and later ended up needing a glaucoma drainage device. And she said that, glaucoma drainage device tube, it was just like such a big operation, a big recovery. And when I compare it to that other surgery I had, I just breezed through it. So I do think there is, even though this is anecdotal, I think there is something to that. Well, so I think we've talked about a lot of high points regarding both what, the clinical trial data regarding these microshunts, and also everyone's personal experience with being the surgeon to implant them. Well, thank you everybody for taking the time to listen to this discussion about the microshunt. I hope hearing about the data and also these surgeons' personal experience with implanting it has been helpful to you.